Hello, everybody. As Prof said, we're just a very short summary of the history, discuss imaging and further management. So the second case is a 24-year-old male we saw last week. He's been in the hospital for 5 weeks with severe, aggressive multiple sclerosis. And according to his family, when he first came into the hospital, he was completely spastic, but he improved over the course of the 5 months. He had minimal mobility, only with physio support, but was not mobilized independently. So we were asked to see him because he developed one-day history of severe abdominal pain that came suddenly. And during the episodes, he gets really sweaty, vomits, and then the pain settles. So, he also has a significant history of constipation since childhood. And it was kind of related, or the neurologist thought it was related to his MS. Now, this patient also initially had a PFA, and this is the X-ray of his abdomen.
Eddie?
Look at the standing large barrel. The center is there. Suppose concerning for large bladder obstruction.
Do you need the distribution of the colonic area?
Its center is.
Yeah. About right. Gemma, do you want to help?
It looks like there's obviously a common lupus small, a large valve in the centre. I'm just wondering if there's a cecum valgus. Is there a large cecum right in the middle, but the cecum valgus?
Why not a sigmoid valgus?
Because sigmoid tends to go the other way, it tends to flip to the side, say, and become the bean shape. So this looks to be the reverse, which is towards cecum valgus rather than sigmoid valgus.
It is a bit more central than usual. The typical cecum should be like a rugby ball this way, shouldn't it? And the sigmoid like a rugby ball the opposite way. So it's kind of, I think you could argue on PFA, either one, but the thing about valgus is the key point, yeah.
Okay, so that's correct. And the radiologist actually thought this is his cecum and right side in the center of the abdomen. So we proceeded with a CT scan, and these are some of the slices from the CT. And again, we can see the cecum and the right side of his colon torted and in a central position. So this patient was diagnosed with a cecal volvulus. He improved a little bit.
There's a little more than just a volvulus in the scan, though, isn't there? Does anyone want to get the bonus points? So certainly a cecal volvulus. Anyone want to comment on the small bowel? We don't have to make this here, but she spoke about diagram down in the last term. Bit of malrotation, so small bowels on the right hand side. Probably incidental.
Yeah, so he improved a little bit, and then he had another episode of severe excruciating pain that sounded ischemic, almost on clinical grounds. So we took him to theatre that night, and this is the image on, this is after just opening his abdomen, and basically his cecum was twisted almost 360 around his axis. He had a very long redundant mesentery, and the peritoneum was also quite long. So we did a right hemicolectomy, and we joined them up, and he's doing well post-op and recovering in a good condition.
So would anyone try the endoscopic decompression for the right side? We saw now in the evening. I mean, it's possible to, I think if the patient is a bit better, it's possible to try it. Mr. Muzzo, Mr. Jimmy, any thoughts? Would you try to colonoscope and flip it back? You can just about see the twist of the base there, can't you? Sort of.
I think even if it was successful, which I think is unlikely, you're likely to need an operation at some stage or other. It's going to be recurrent problem. So,
but to scope him and then maybe to do a laparoscopic right hemi. The problem here is his medial colon, so that means he probably needs a resection to fix it, doesn't it? But would you try and break the two, or do you think just go ahead and?
Actually, I would go ahead and go into a post-op one of these laparoscopically. It's very difficult to figure out where the small bowel mesentery is supposed to be, and you're worried it's going to be a twist in the small bowel mesentery in the situation.
Yeah, it's very hard. Actually, it can be very difficult, can't it, to orientate yourself. Okay. So Shane, tell us what you saw.
Yeah. So thanks, Prof. Colin. So my name is Shane McKenna, and I've been asked to speak to you briefly about the colonoscopy of this patient. So it's a 60-year-old male who is 3 weeks post low anterior resection with loop ileostomy formation. This was done for rectal cancer. The patient was then subsequently diagnosed with bilateral PEs and a pelvic fluid collection, and this colonoscopy was done as a result. So just before we begin, let's orientate ourselves. So closest to the camera, we can see the rectum, and as we just move forward, you can see more of the colon. And then, just as we approach here now, what do we see in front of us? So on the right-hand side, you can see the correct lumen, which is continuous with the rest of the bile, and then to the left, we can see where the anastomotic dehiscence has occurred, and beyond that then it leads into the leak cavity itself. You can also note here, and here is the staples from where the anastomosis has dehisced. We'll just move on then.
So this is a leak.
It's a leak, sorry, it's an anastomotic leak, yeah. So we're just going to take now a look into the correct lumen, just to check the tissue status of the proximal colon. And as you can see, the tissue is well perfused and looking quite healthy. So now we're just going to withdraw.
The rectum segment is taken out. This is really his descending colon, which have been brought down to form the anastomosis.
So we're just going to look into the leak cavity itself. And although there's a little bit of blood, as you can see here, this white tissue, it's granulation tissue, which signifies healing. Yeah, so that's pretty much it. So in this case, endosponges were the treatment that were used to treat this this leak. They're generally used for anastomotic leaks in the low rectal region. It involves endoscopically placing a highly porous sponge into the leak cavity. They're sized and made to fit the actual cavity specifically, and they are attached to a drain tube, which is then connected to a negative pressure vacuum. This leads to continuous suction, which continuously drains any fluid, and this, as a result, reduces the risk of infection, and also promotes granulation tissue formation. They're an important procedure to know in that, as we know, anastomotic leaks occur in 10 to 15% of anastomosis formations.
Yeah, fantastic. So we're going to get back to this patient, the outcomes and topics of